It's time for another warm-up review. Let's get going. Which portion of the brain is supplied by the anterior cerebral artery and also the middle cerebral artery? So this is the medial surface of the cortex, down deep in the longitudinal fissure. This is where the motor and sensory cortex for the legs and feet are found. Your middle cerebral artery supplies the lateral surface of the cortex. This includes Broca's area, Wernicke's area, and also the motor and sensory cortex for the face, arms, and upper body. Next, what are the symptoms of normal pressure hydrocephalus? Well, normal pressure hydrocephalus causes a reversible form of dementia where you have expansion of the ventricles. Now, most of the time dementia is irreversible, but this is the one where you can actually treat and make better. Now, the mnemonic for the symptoms is wacky, wet, and wobbly. So a patient would have dementia, urinary incontinence, and ataxia. Next, a 76-year-old man who recently suffered a stroke is brought to the clinic by his wife. She says that he now shaves only on the right side of his face, and he eats off only the right half of a plate. When asked to draw a clock, he draws just the right half of the clock face. A lesion in which area of the brain is most likely responsible for these findings? So this is hemispatial neglect, where the patient is basically unaware of one side of his body or one side of his world. So this is usually due to a cortical lesion in the non-dominant parietal lobe, which in most people is the right parietal lobe. All right, that's it for the warm-up. Let's get to that lecture.
In this video, we're going to be talking about pharmacodynamics, which is the relationship between the drug concentration and the effect that drug produces at that concentration. So let's start with potency and efficacy. We're going to look at some graphs that are somewhat similar to the Michaelis-Menten graphs, but instead of talking about the action of an enzyme on a substrate, now we're talking about the action of a drug to produce some therapeutic effect. Efficacy is related to the maximal response or effect that a drug can produce. So we plot dose on the x-axis, but we've plotted it using a logarithmic scale rather than a linear scale, and that gives the curve sort of an S shape. And then over on the y-axis, we have the maximal response, the percentage maximal response, which is the maximal effect that the drug can produce. So think about a blood pressure drug, for instance. If you give a little dose of that blood pressure drug, you might lower the blood pressure a little bit, like 2 points. If you give a big dose, you might lower the blood pressure a lot, maybe 20 points. And at some point, there's a limit to how much you can possibly lower the blood pressure. Even if you give more and more and more of the drug, there's a limit to how much the blood pressure is actually going to drop. And that limit is the maximal effect. That maximal effect is basically the efficacy. Now, drug B is a second blood pressure drug with a curve that looks like this. So maybe drug A is able to lower the blood pressure by a maximum of 20 points, but drug B can only lower the blood pressure around maybe 14 points. So we would say that drug A has a greater efficacy than drug B. So efficacy is only talking about that maximal response, the maximal effect. Efficacy says nothing about the dose that's given. Now, potency is related to the amount of drug that's needed to achieve a given effect. So efficacy has nothing to do with the dose given, but potency is all about the dose that's given. Now, I'm not going to go into detail about how we calculate the potency, but think about the example of blood pressure drugs again. It looks like we get to the maximal effect of this drug at about maybe 1.5 or 2 on this scale. Let's say that's 2 milligrams as an example. Now, drug C has the same maximal effect. So what could we say about the efficacy? Well, both these drugs are capable of achieving the same maximal effect. They both lower the blood pressure by 20 points or whatever. So the efficacy of these two drugs is identical. They're both equally efficacious. But for drug C, you have to give a much larger dose to achieve that same maximal effect. It looks like you have to give something like 100 milligrams to lower the blood pressure 20 points. So the drug A is much more potent than drug C is. Drug A has a higher potency. Now, how does adding an antagonist affect potency and efficacy? Now, this is another 4 or 5-star topic. Make sure you know how to interpret all these graphs. Here in red, we see a receptor agonist, and then you see that a competitive antagonist has been added to the system. So this is somewhat similar to the competitive and non-competitive enzyme inhibitors. Now, here we're not inhibiting an enzyme, we're antagonizing a receptor, but the basic concept is the same. If the agonist is acetylcholine, for instance, stimulating a cholinergic receptor, then an example of a competitive antagonist would be atropine. So what happens when you add atropine to the system? How does that affect the dose-response curve of acetylcholine, which is the agonist? Well, the competitive antagonist shifts the curve to the right. It takes a larger amount of the agonist to achieve the same response. So, is that changing efficacy or potency? Well, that changes potency. You're still going to reach the same maximum effect, but it takes more of the agonist to reach that effect. In this graph, the red curve is the agonist by itself, and the green curve is where you've added a non-competitive antagonist. Now, with a non-competitive antagonist, the maximum effect is lower. You can't overcome the antagonist simply by adding more agonist. So in this situation, the efficacy is decreased. In this graph, we're not looking at an antagonist, but rather something called a partial agonist. A partial agonist is a substance that stimulates or agonizes the receptor, but not as strongly as a full agonist does. So because it has a weaker agonist effect, the maximum response is lower, which means that a partial agonist has lower efficacy than a full agonist. But potency is independent. A partial agonist could be more or less potent than the full agonist is. It can shift the curve either to the right or to the left, independent of what it does to the efficacy. To demonstrate that, look at this graph from your study guide. The green curve is the full agonist, and the orange and pink curves are two different partial agonists. Now, with either of these partial agonists, the maximum effect is lower, so efficacy is lower. But with partial agonist A, the curve is shifted to the left, which means increased potency. At a dose of 1, say 1 milligram, the partial agonist gives you a response of 25 or 30% of the maximum, while the full agonist response is only about 5% of the maximum. For any given dose, the partial agonist gives you a bigger response, up to about 15 milligrams when the curves cross because the partial agonist has lower efficacy. With partial agonist B, the curve is shifted to the right and potency is lower. So for any given dose here, the full agonist is going to give you a bigger effect. So with partial agonist, the efficacy is always lower, but the potency could be higher or lower. Let's talk about drug safety and therapeutic index. Now, LD50 is the dose of a drug that's lethal to 50% of the people. LD is lethal dose, so it's the dose that's lethal to 50% of the people. And ED50 is the dose that is effective for 50% of the population. So if you divide LD50 by the ED50, that gives you the therapeutic index. And you can have a high therapeutic index or a low therapeutic index. Which is better? Well, safer drugs have a higher therapeutic index. So a high therapeutic index means the drug is safer. Let's think about that mathematically. Look at the numerator. If LD50 is higher, that means it takes a higher dose of medication to kill the patient, and that makes the drug safer, right? Then consider the denominator. If ED50 is small, that means that a very, very small dose of the drug is going to be effective, so that's also going to increase your therapeutic index. So therapeutic index is good. You can have a high therapeutic index either when the lethal dose is very, very high or if the effective dose is very, very low. What are some examples of drugs with a low therapeutic index, where the toxic dose is only a tiny bit higher than the effective dose? Well, these tend to be drugs that we have to monitor on a regular basis, such as seizure drugs, lithium, digoxin, and warfarin. That's why we monitor them, because they have a low therapeutic index, and the effective dose is pretty close to the toxic dose. You also need to be familiar with the therapeutic window, which just means the range of doses of a drug that are both safe and effective. If a drug has a wide therapeutic window, that means there's a big gap between the effective dose and the toxic dose. A narrow therapeutic window means that that gap is pretty small, and it's too easy to go from a nice safe therapeutic dose to a toxic dose. So now we're ready for the end of session quiz. So pause the video, answer those questions, and then we'll go through them together. First question. An investigator has developed 2 new preparations of insulin. Both preparations can lower the blood glucose by a maximum of 100 milligrams per deciliter. It takes 16 units of insulin preparation A to lower the blood glucose by 100 milligrams per deciliter. It takes 12 units of preparation B to lower the blood glucose by the same amount. Which insulin preparation has the higher efficacy and which has the higher potency? Well, efficacy is a reflection of the maximal effect a drug can produce. Both of these drugs lower the blood glucose by the same maximum amount. So that means both drugs have equal efficacy. But for potency, you have to look at the amount of drug required to produce a given effect. Since it takes less of insulin B to achieve the same maximal effect, we can say that insulin preparation B has a higher potency. Next, your patient is taking experimental drug Z to lower his LDL cholesterol. When he's given the antagonist drug X, the potency of drug Z is decreased, but efficacy is unchanged. Doubling the dose of drug Z is shown to overcome the inhibition by drug X. So is drug X a competitive or non-competitive antagonist of drug Z? Well, if you can overcome an antagonist by adding more of the agonist, which in this case would be drug Z, then drug X must be a competitive antagonist. And remember, competitive antagonists will reduce potency, but they will not change the efficacy. Last question. Drug A has a therapeutic index of 10 to 1, while drug B has a therapeutic index of 2 to 1. So which drug would be considered safer? Well, there are a couple of ways to approach this. One way is you can remember that the therapeutic index is LD50 over ED50. So if drug A has a lethal dose of 10, say 10 grams, but drug B has a lethal dose of just 2 grams, and the effective dose is the same for both, in this case 1 gram, then drug A is much safer. Or the second way is just to remember that a high therapeutic index means the drug is safer. So 10 to 1 is a lot higher than 2 to 1. So again, drug A is safer. Well, that's all for now. I'll see you next time.